And then, and in 5, start when you're ready in 5.
Total parenteral nutrition forms part of a nutritional strategy to promote recovery after major surgery. Despite being a life-saving therapy, TPN is not the preferred method of feeding a patient because it carries a much higher incidence of complications and it's a very expensive form of therapy. Hi, my name is Jordaan. I'm a cardiothoracic surgeon and intensive care specialist, and today we will be discussing the role of TPN in the perioperative period following major abdominal surgery. Ever since 1936, when study demonstrated a direct relationship between perioperative weight loss and operative mortality, nutritional support of surgically and critically ill patients has undergone significant advances. The WHO cites malnutrition as the greatest single threat to the world's health problem, as the reported in-hospital prevalence of malnourished patients on admission ranges up to 50%. Perioperative nutrition has been convincingly shown to improve clinical outcome in patients undergoing major gastrointestinal surgery, reduces costs, and to decrease the length of hospital stay. The mechanism of action seems not only to be improved nutritional status by providing a higher caloric intake, but primarily a refocused immune response. The immunoinflammatory response following trauma as a result from major abdominal surgery overrides the normal response to starvation, where lean body mass is preserved, and instead promotes a progressive loss of skeletal muscle. The surgical insult increases the basal metabolic rate and up to 40%. The lean body mass ranges from about 0.5 to 1% per day, and in combination with the reduction of protein synthesis brought on with inactivity, bed rest, and immobility, this leads to a reduction of muscle cross-sectional area of about 3 to 4% per day. This is compounded by the difficulty in providing nutritional support with therapy after major abdominal surgery. Patients with sepsis and enteral nutrition are likely to be underfed due to their poor gastrointestinal tolerance to fluids and nutrition and feeds. Such a condition is associated with the development of progressively increasing energy debt. Enteral nutrition often provides about half of the measured energy expended over the first week in the ICU. On admission, many of our patients undergoing major abdominal surgery will inevitably have some form of malnutrition due to their underlying abdominal pathology. Between 15 to 70% of patients following major surgery in the ICU will be malnourished, increasing the incidence of complications and infection. And it prolongs the ICU and hospital stay and ultimately leads to an increased mortality. Johan and colleagues in 2014 managed to show a direct correlation between protein calorie intake in the ICU patient following major surgery and the post-operative mortality. Major stress such as surgery can subject a patient to a whole host of metabolic and physiological changes. The body responds to such a stress by increasing its basal metabolic rate, using up its nitrogen stores and creating a negative nitrogen balance. An increase in gluconeogenesis, as well as the synthesis of acute phase proteins, are also observed. The body scavenges for the required nutrients during these times of stress, and the perioperative nutritional supplementation should actually blunt the catabolic effects of such a high energy state. But in many patients, it may not be feasible to initiate enteral nutrition early due to a relative or an absolute contraindication, and subjecting the patient to prolonged intervals without nutritional support. The days following a surgical insult is influenced by a cascade of inflammatory and hormonal mediators causing severe metabolic changes throughout the body. The body goes through a cytokine-induced phase of heightened inflammation, followed by a phase of immune suppression. The initial response to injury is also known as the SIRS phase, and this is followed by the CARS phase. CRP is a clinical marker used to identify the different phases. It's a protein marker used to monitor the presence, the intensity, and the recovery from the inflammatory process. Drop in the CRP to about 37.5 means there's a decrease in inflammation, and this also signals the start of the CARS phase. And then the three systemic key responses follow, and they are different during the SIRS and the CARS phases. The initial response to injury is also known as the SIRS phase and is characterized by an increase in the pro-inflammatory cytokines with an increase in the production of free radicals and also an increase in the oxidative stress. But during this phase, you have a decrease in the metabolic rate. During the anti-inflammatory phase, there's a drop in the anti-inflammatory cytokines, and the immune suppression starts at about approximately day 7 to day 10. And this is also seen as an increase in catabolism and the loss of energy expenditure. The different phases in critical illness and the effect it has on energy expenditure can be divided into three distinct phases. The acute phase is composed of two periods: an early period, defined by metabolic instability and severe increase in catabolism. And then we have a late period, defined by an increased catabolism, significant muscle wasting, and a stabilization of the metabolic disturbances. Lastly, the post-acute phase follows with an improvement in rehab, or the patient can continue with a persistent inflammatory and catabolic state, which then prolongs the hospital in the ICU stay. The resting energy expenditure peaks over the 4 to 5 days and then continues for up to 9 to 12 days after the insult. And in many patients, this may persist up to 21 days. Approximately 16% of your total body protein is lost during the first 21 days, with most of that, up to 67% of that protein loss, coming from skeletal muscle alone. Therefore, your energy goals should be tailored depending on the phase of the patient and where he finds himself after the insult. Lower energy provision is suggested early in the resuscitative phase, with liberalization of energy delivery as the patient enters into the rehabilitation phase. The Aspen and the ESPEN guidelines propose that all patients be nutritionally evaluated and on admission to identify any form of malnutrition. Using the NRS or the Nutrix screening score or the Nutrix score, both take into account the nutritional status of the patient and the disease severity, and this identifies the patient at risk very early. In high-risk patients in whom enteral nutrition cannot be initiated, early parenteral nutrition should be started using a hypocaloric dosing for the first 7 days to avoid overfeeding. In the low to high-risk patient, not reaching nutritional goals within the first 7 to 10 days will definitely benefit from a peripheral parenteral nutrition, thereby avoiding most of the central complications associated with TPN. The degree of insult and the baseline nutritional status and the host response to injury impacts the perioperative nutritional needs. Various equations and methods can be used to predict or measure the energy expenditure, and the gold standard at the moment is indirect calorimetry. It is unfortunately very expensive, and you need trained staff. So we go on a base need of an energy requirement of 25 to 30 calories per kilogram per day, and we can decrease this with about 30% if a patient is ventilated or paralyzed. Lipids are the most important intravenously, and the use of intravenous fat emulsions based solely on soybean oil, which is rich in 18 carbon omega-6 fatty acids, should be avoided at all costs due to their high likely pro-inflammatory effects. So according to Aspen and ESPEN, you should give them a balanced solution made of SMOF emulsions, which should be used. And this contains the soya oils, medium chain triglycerides, olive oil, and fish oil. And remember that intravenous lipids should not exceed 1.5 gram per kilogram per day. Special attention should be paid if propofol is administered, since it is also a sort of fatty acids. The lipid solution contains 1.1 calorie per milliliter, and you can easily give up to 250 to 500 calories per day. And this can also provide a large calorie load over time, over and above the normal nutritional support. In patients who do not tolerate full dose enteral nutrition, during the first week in the ICU, the safety and benefits of initiating parenteral nutrition should be outweighed and should be evaluated by a case-to-case basis. Taken together, the route, the caloric and protein target, and the timing should no longer be considered as three different entities, but should rather be integrated in a more comprehensive approach, considering all of these aspects. After defining the time and the route, the energy and protein goals should then actively, progressively be increased after 48 hours to avoid overnutrition. However, administration of marked amounts of carbohydrates and lipids can also lead to hyperglycemia and also to liver dysfunction, and test abnormalities of high fat administration can lead to lipid overload, and especially unsaturated fats can impair lung function and pulmonary function and also increase immune suppression. In terms of nutritional support, it is generally accepted that earlier is better than later, and enteral is superior to parenteral, and that the quality of nutrients appears to be more important than the quality. Goals of nutritional support have changed in the past few years from attempts to preserve low body mass following a surgical trauma stress to actually efforts to attenuate the hyperbolic response, to reverse the loss of lean body mass, to prevent oxygen stress, and to favor the modulation of the immune response with early enteral feeding. TPN has shown to significantly affect the post-operative outcome in the severely malnourished patient. Because of this, its direct central venous administration, parenteral nutrition can rapidly improve nitrogen balance. It also allows for quicker lymphocyte recovery and improved wound healing. Although TPN has many benefits, there are considerable risks to its use. Volume overload, for instance, can cause respiratory compromise, particularly in individuals with marginal cardiorespiratory reserve. Hypoglycemia, along with its metabolic consequences, can also result in adverse outcomes if allowed to remain uncorrected. But TPN still remains a very good alternative in a patient with decreased nutrition, high risk, which cannot tolerate enteral nutrition. Thank you.
Okay, great. Thank you so much for that, Dr. Just one thing, there was at one point the dogs in your house were quite loud. And what I've done is I've managed to find it on the video. I'm going to show you. And it's actually, you paused just before that. And then I think if we just, and then there's a natural stop after that. So it's actually, it's towards the beginning of your presentation. I'm going to show you. And then you can just find your place, and then we can just re-record that spot as well. And if you can try not to adjust the camera angle so that it can do like a seamless transition. I'm going to just put it on here so we can see.
How was the talk? Did I speak too fast, too slow? Did I stumble on my words?
Nee, dit was alles baie goed geweest. Dit was net daai eerste deeltjie waar die honde geblaf het. And then, Jackie, I don't know if it was on my side, whether I lost connectivity, because there were sections where I couldn't hear Doctor, but I'm thinking that it was my connectivity.
Yeah, it's because I had seamless
you was seamless. Okay,
audio,
then that's
yeah.
great.
So
Dit was net daai begin, Doctor. Die res was
great. Or should I redo the whole thing again?
It's entirely up to you. If you want to redo the whole thing, what I'm going to do is I'm just going to play the part where the Honda bluff.
Well, I'm going to bring them in so they won't bother us anymore.
Okay. Let's just so you can decide now if you want to just find that spot and redo it, or if you want to redo the whole thing. I'm going to just play that for you now quickly.
Perioperative malnutrition. Perioperative nutrition has been convincingly shown to improve clinical outcome in patients undergoing major gastrointestinal surgery, reduce its cost, and to decrease the length of hospital stay. The mechanism of action seems not only to be improved nutritional status by providing a higher caloric intake, but primarily a refocused immune response. The immunoinflammatory response following trauma
I don't
as
think
a
I've got it in the
result
right
from
spot.
major abdominal surgery overrides the normal response to starvation, where lean body mass is preserved, and instead promotes a progressive loss. Ever since 1936, when study demonstrated a direct relationship between perioperative weight loss and operative mortality, nutritional support of surgically and critically ill patients has undergone significant. Oh, they made a huge racket.
Yeah, so that was quite.
A direct relationship.
But I can restart the entire thing. I can start from the beginning, and that won't be a problem.
Nutritional.
Oh. So, was that the dog now or on the recording?
That was the dog now.
Oh gosh.
I'm back.
Okay.
Sorry.
So, what do you want to do, Doctor? Do you want to start again?
I think I'll just redo it because I stumbled over a lot of my words. It's just performance anxiety, I guess.
Yeah, that's no problem. So yeah, let's do that again. We'll start again, and then you've got all the dogs in the room with you. But if there is, so what I'm going to suggest, if there is a big bark or what have you, I'm thinking what we can do then is you can just do a pause and then start again on that section so that we can then just stitch it together.
Okay, good. Let's do that.
So yeah, so then we just carry on, start that section again where you were, and then carry on, but just give it like a 5-second pause so that we can then just edit that for you.
Okay.
All right, and now everything's chip still.
Okay.
Thank you. Okay.
Total parenteral nutrition.
Wait. Sorry, doctor. Sorry. I was just putting myself in the background and I pushed the wrong button. So just give me a second. Okay. All right. I'm going to give you in 5. So, and in 5.
Hi. Total parenteral nutrition forms part of our nutritional strategy to promote recovery after major surgery. Despite being a life-saving therapy, TPN is not the preferred method of feeding a patient because it carries a much higher incidence of complications and is a very expensive form of therapy. Hi, my name is Johan Jordaan. I'm a cardiothoracic surgeon and an intensive care specialist, and today I will be discussing the role of TPN in the perioperative period following major abdominal surgery. Ever since 1936, when study demonstrated a direct relationship between preoperative weight loss and operative mortality, nutritional support of surgical and critical ill patients has undergone significant advances. The WHO cites malnutrition as the single greatest threat to the world's public health, as a reported in-hospital prevalence of malnourished patients on admission ranges up to 50%. Perioperative nutrition has convincingly shown to improve clinical outcomes in patients undergoing major gastrointestinal surgery and also reduce the cost and to decrease the length of hospital stay. The mechanism of action seems not only an improved nutritional status by providing a high caloric intake, but primarily a reinforced immune system. The immune inflammatory response also following trauma as a result from major abdominal surgery overrides the normal response to starvation where lean body mass is preserved and instead promotes a progressive loss of skeletal muscle. The surgical insult increases the basal metabolic rate by approximately 40%. The loss of lean body mass ranges from 0.5 to 1% per day, and in combination with the reduction in protein synthesis brought on with inactivity, bed rest, and immobility, leads to a reduction of muscle cross-sectional area of between 3 to 4% per day. This is also compounded by the difficulty in providing nutritional therapy to major abdominal surgery patients. Patients with sepsis, for example, on enteral nutrition are likely to be underfed due to their poor gastrointestinal tolerance to liquids and feeds. Such a condition is associated with the development of a progressively increasing energy debt. Enteral nutrition often provides about half of the measured energy expended over the first week in the ICU. On admission, many of our patients undergoing major abdominal surgery will inevitably have one form of malnutrition due to their underlying abdominal pathology. Between 15 to 70% of patients following major surgery in the ICU may be malnourished, and this increases the incidence of complications and infections, and also prolongs the ICU and hospital stay and ultimately lead to an increased mortality. Jordaan and colleagues in 2014 managed to show a direct correlation between protein and calorie intake in the ICU patient following major surgery and post-operative mortality. Major stresses such as surgery can subject the patient to a whole host of metabolic and physiological changes. The body responds in such stress by increasing basal metabolic rate, using up the nitrogen stores and creating a negative nitrogen balance. An increase in gluconeogenesis, as well as the synthesis of acute phase proteins, are also observed. The body scavenges for the required nutrients during the times of stress. Perioperative nutritional supplementation, therefore, should blunt the catabolic effect of such a high energy state. But in many patients, it is not feasible to initiate enteral nutrition due to relative or absolute contraindications, and this subjects the patient to prolonged intervals without any nutritional support. The days following an insult is influenced by a cascade of inflammatory and hormonal mediators, causing severe metabolic changes throughout the body. The body goes through a cytokine-induced phase of heightened inflammation, and this is followed by a phase of immune suppression. And the initial response to injury is also known as the SIRS phase, and this is followed by the CAS phase. CRP is a clinical marker used to identify the different phases. It is a protein marker. It's used to monitor the presence, the intensity, and also the recovery from inflammatory process. A drop in the CRP to around 75 means that there's a decrease in inflammation, and this signals the start of the CAS phase. The three systemic key responses also follow, and it's different during the SIRS and the CAS phase. The initial response to then injury is also known as the SIRS phase, and this phase is characterized by an increase in pro-inflammatory cytokines with an increase in the production of free radicals. It also is seen with an increase in oxidative stress, but with a decrease in metabolic rate. Lastly, during the anti-inflammatory phase, there's a drop in the pro-inflammatory cytokines, and the immune response starts to drop at approximately day 7 to 10. And this state is known or seen with the increase in catabolism and a loss of energy expenditure. The different phases of critical illness and the effect it has on energy expenditure can be divided into three distinct phases. The acute phase is composed of two periods. An early period defined by metabolic instability and severe increase in catabolism, and a late period defined by an increased catabolism, significant muscle wasting, and stabilization of the metabolic disturbances. The post-acute phase follows lastly with the improvement and rehabilitation of your patient, or the inflammation may persist and the catabolic state may be prolonged, also prolonging the hospital stay and the ICU stay. Your resting energy expenditure peaks at day 4 to day 5, and it continues to remain high for the first 9 to 11 days, and it may persist up to 21 days. Approximately 16% of the total body protein is lost in the first 21 days, with 67% of the protein loss coming from your skeletal muscle alone. Therefore, energy goals should be tailored depending on the phase the patient finds himself after the insult. Lower energy provision is suggested early in the resuscitative phase, with obviously liberalization of energy delivery as the patient enters into the rehabilitation phase. The ESPEN and the ASPEN guidelines propose that all patients be nutritionally evaluated during admission to identify malnutrition. Using the NRS, or the National Screening Score, or the Nutric score, both of whom take into account the nutritional status of the patient as well as the disease severity, can identify a patient at risk very early. And then we can tailor the nutrition. In high-risk patients, in whom enteral nutrition cannot be initiated, early nutrition, parenteral nutrition should be started using a hypocaloric dose for the first 7 days to avoid overfeeding. In the low to high-risk patient that cannot reach the nutritional goal within the first 7 to 10 days will also benefit from parenteral nutrition, but now we can use peripheral parenteral nutrition, avoiding most of the central complications associated with TPN. The degree of the insult, the baseline nutritional status, and the host's response to injury impact the perioperative nutritional needs. Various equations and methods can be used to predict and measure the energy expenditure of a patient, and the gold standard currently being the indirect calorimetry. It is, however, expensive, and you need trained staff to perform this. So we all use the energy requirements of about 25 to 30 calories per kilogram per day, decreasing it with about 30% in a ventilated or paralyzed patients. Lipids are very important. The use of intravenous fat emulsions based solely on soybean oil, which is rich in 18 carbon omega-6 fatty acids, should be avoided due to the likely pro-inflammatory effects. So aspirin and aspirin suggests that a balanced SMOF emulsion should be used, and this contains soya oils, medium-chain triglycerides, olive oil, and fish oil, and that the intravenous lipid load should not be in excess of 1.5 gram of lipids per kilogram per day. Special attention should be paid if propofol is administered, since it is also a source of fatty acids. The lipid solution contains approximately 1.1 calorie per milliliter, and it can provide a large calorie load over a day, over and above the normal nutritional support. In patients who do not tolerate full-dose enteral nutrition during the first week in the ICU, the safety and benefits of initiating parenteral nutrition should be weighed on a case-to-case basis. Taken together, the timing, the route, the calorie and protein target should no longer be considered as 3 different entities, but should rather be integrated into a more comprehensive approach, considering all of the aspects of the patient. After defining the timing and the route, the energy protein goal should be achieved progressively and not before the first 48 hours to avoid overnutrition. However, administration of marked amount of carbohydrates and lipids can lead to hypoglycemia and liver function test abnormalities, while high fat administration can lead to lipid overload, and especially unsaturated fats, which can then lead to pulmonary dysfunction and immune suppression. And close monitoring of triglycerides and liver function tests are then proposed. Patients with open abdomens should also be compensated for their volume and fluid loss, as well as the protein loss, and approximately 15 to 30 grams of protein per liter of exudate should be added to the normal nutritional values. In terms of nutritional support, it is generally accepted that earlier is better than later, that enteral is superior to parenteral, and that the quality of nutrient appears to be more important than the quantity. The goal of nutritional support have changed in the past few years from attempts to preserve the lean body mass following a surgical or traumatic stress to efforts to attenuate the hyperbolic response, to reverse the loss of lean body mass, to prevent antioxidant stress, and to favorably modulate the immune response with early enteral feeding. TPN has been shown to significantly affect post-operative outcomes in the severely malnourished patient. Because of its direct central venous administration, parenteral nutrition can rapidly improve nitrogen balance, which also allows for a quicker lymphocyte recovery and improved wound healing. Thank you.
Well done. I thought that was fantastic.
Ja.
Was that a bit better? At least we didn't have any dogs in the background.
Nee, ek dink dit was baie goed geweest, Dr. Jordaan. Lekker gesels, praat, very natural. So I think that was a good take. Jackie, what do you think?
I agree. There were no audio glitches on my side. It was seamless. And also, where there are little stumbles, it's great because we would like to keep it natural. You know, not everybody's going to talk perfectly each time. So don't worry about that. It's all good. I'm very happy with the recording. I think it was fantastic. So I'm glad that we've got it and that you have a room full of, and you've got an audience in your room as well now.
Thank you. Lisa, was that what you had in mind with my presentation?
Yeah, no, it was really good, and you know, it's all aligned with the guidelines, and the, you know, it aligns with the guidelines. What we also want to portray, because remember, the message across ISIMIA is important because different markets have different needs, right? So what is very common knowledge, if I can put it like that, for us is not necessarily the case for other countries. So that, I think that was really good, how you incorporated the guidelines and that type of thing. Very good.
Okay.
Dankie.
Well, thank you very much.
Baie
No,
dankie
thank you
Dr.
very much for
Jordaan.
inviting me.
Ek
And Jackie, thank you, and sorry for wasting your time. But thank you
It's
for
no
being so
waste of
patient.
time at all. No problem. It's really not a problem. So thank you.
Thank you very much. You have a wonderful
Thank
day.
you.
Thank you. Bye-bye.
Okay. Take
Dankie
care.
dokter.
Bye.
Goed. Bye.